Well, good morning, everybody. My name is David Gerdel, and it's a great pleasure for me to do this presentation online about cracks in teeth. And this presentation is a common work together with my mate Stefan Broe from Belgium. And let's put a few words about that. I am belonging to a group that you might know, which is called the Biomulation Group. This group is gathering technicians, dentists, researchers, and some of the well-known mentors in the field of the biomedical dentistry. And we're all together working on this minimally invasive approach. And for this presentation, some of the dentists here helped me a lot, and it's really a group effort. This is not really and only my presentation. Most of all, my dear friend Stefan Broe, as I said, from Belgium, is a real crackologist, is a real specialist for that. And we worked on cracked on teeth together, and we worked also and published on the rubber dam techniques that can help to improve a little bit our skills, especially when we are treating very complicated things and very small things, as we are doing with cracks, and in particular managing the synergy that we can get, putting together the benefits of the magnification and of the rubber dam use. And then we've also worked hard with my Brazilian friend Lucas Naves. So Lucas Naves is a specialist for scanning electron microscopy. And what we did together, that we did some replicas of clinical situation, and then we studied those replicas under scanning electron microscopy in an attempt to understand a little bit better what happened in such situation. We also published a paper on that, and you will see in this presentation the amazing stacked picture of Lucas, and also some great scanning electronic microscopy pictures, just in an attempt to understand a little bit better and to learn about our failures, trying to be a better dentist next time we have to face such a problem. And the third guy that worked a lot for this presentation is called Marco Gresnik, is from the Netherlands, and we've just published a paper together about the margin elevation technique. And when we address cracks that go far underneath the gum level, it is also crucial to understand how we can elevate those margins. So thanks to those guys that help a lot for the building of this presentation about cracks. In fact, what is a crack? A crack is not a disease. A crack is not really and specifically in any case a problem. A crack is just a finding that we have in a tooth, and we should not consider it as a diagnosis in itself. And we will spend 1 hour together to understand why, for some cases, cracks could be an issue and need to be restored and addressed. Because the problem that we have is anytime that we have a crack or a fracture in a tooth, this is something that will weaken the structure of the tooth, and then this is an open door for bacteria. So we know that once we have a crack, bacteria will penetrate in that crack, because it's like Grand Canyon for those bacteria, and we can get some pulpal response, some pulpal inflammation based on the location, on the direction, and on the extent of those cracks. So this is why this topic is of major importance. So the question is quite simple. Next time we have a new patient in the office, and the patient is just coming for a regular control, nothing special, it's just a recall appointment, and we see those kind of teeth that are far from perfect, but the patient doesn't complain at all. So what do? No complaint of the patient, we don't do anything. Solution A. Maybe B, we can change those old amalgam for new restoration that could be direct restoration, indirect restoration, or maybe why not a crown, because the extension of the restoration is already quite big. Or why not taking out the tooth, considering we can do anything good on that tooth because the structures are too weak, and replace it by an implant. Why not? There are many questions then come here. This is why we need really tools to understand and to establish an early diagnosis on that one, to be able to take those kind of decisions. And finally, can we draw after this presentation a clear strategy and some guidelines to follow every time we are facing such a problem on the tooth of a patient? So don't worry about the literature. I know that we are online and you have time to stop the presentation, to take some notes and to find some paper, but we've gathered in a Dropbox shared file for you, papers in PDF already. So you will have only to scan this QR code and you will get an access to this folder. Then copy and paste. Please don't drag and drop, just copy and paste the file on your computer, and later on you will enjoy the literature if you are interested to read some paper and to go further about that topic. This is the menu I'm suggesting to you for today. First of all, we will spend a little bit of time about the diagnosis, just in an attempt to understand why those cracks could be preoccupating, and why we should understand what a crack really is. It will lead us to a natural chapter of this presentation, which is what is the biomechanic, what are the biomechanics features of the tooth, and how a tooth could be weakened by the existence of a crack. And finally, once we've understood a little bit better how it works, what kind of treatment can we propose to a patient that has a cracked tooth. So let's start with the diagnosis, if you don't mind. The first time the patient comes in the office, we just have to do the diagnosis without removing the restoration, because most of the patient, they don't ask for any treatment. They just want to know if anything's okay. So without moving the restoration, we should be able already to see the cracks and to establish a first diagnosis. So what are the tools and the techniques for this visual inspections that we can have? We have some tools and also some testing like magnification, transillumination, fluorescence suppression and probing that we will develop in a moment. First of all, I don't think that nowadays it's possible to work without a strong magnification, and we are currently working mixing the use of loops. I've got 5.5 and 6.0 magnification loops, and for sure if you have, the opportunity to use a microscope, which is not always available or affordable, this is really of the major help. Having the opportunity to manipulate magnification between 12 and 20 will be of a great help in the diagnosis, of course. So this is just for you to see what we can see with the naked eye. So it's not much. Using loops already we have a great improvement, and we can discover some strange stuff on that tooth like cracks. And this is the comfort zone 12 type magnification under the microscope. This is something that we can really easily work with because we have a nice depth of field, and it's quite easy to manipulate. It's a great mix between seeing very good and very properly what we should see, and also being really easy at work, which is also very important. But finally, if we want to inspect a little bit better details, we can just push a little bit of magnification 22 times for the really small details that we would like to diagnose. Then if we can see the cracks, we can see them better using some special light, and especially light which is transmitted through the tooth, which is called transillumination, will be of a greater help. So we have to remove other light sources in the room, and we will be able, applying that kind of tool, this is here the Microlux from Adent, on the tooth, we will be able to see better the extension, the existence, the location of those cracks. And If in visible light we don't have enough information, we can just jump to some other lights like purple light or fluorescence or UV light that will also provide some information. Because what happens when we eliminate a tooth with the UV light or with the purple light, violet light, the tissue, they start to enter, they start to produce some fluorescence. The natural fluorescence of enamel is very poor, and the natural fluorescence of the dentin is really high. It's green, blue fluorescence. So we can make the difference between enamel and dentin, but especially we will make the difference between the infected dentin and the affected dentin. And as we know that those cracks are full of bacteria, we would like to check if the coloration under visible light that we see corresponds to bacteria or not. And we will use a property under violet light. Here, for instance, we are using a curing unit, a polymerization unit that has a special mode which is called the DT mode, detection mode, and this detection mode is producing some purple light, and this light will make bacteria become fluorescent. Why? Because we know that bacteria are producing some byproduct of their metabolism, which is called porphyrin. And porphyrin, when they are present, they will get fluorescent in red. So meaning that under UV light, we can see the bacteria in red, and under normal light, we wouldn't be able to see those bacteria. So you can imagine the great help that it can provide us. Then beyond what we can see under different kind of lights, we can also test a little bit the tooth, test the vitality, test the pulp, and a little bit with the pressure. So what about vitality tests? So the most common one is to use some cold test, but let's say that this is not really effective because we don't really know if this is that tooth that we are testing that is responding on the other one, and if the patient, it's a very brutal test, so the patient will just react and we don't really know if the reaction of the patient is due to the cold or to some pulpal response. So it's not very significant, and we highly prefer the electric way of testing the pulp, which is more progressive, which is more selective and specific of one tooth. But still, there is a problem with that. When we ask the tooth to respond, so is it someone vital in there? We don't really know what is responding to us. Especially with multi-radicular teeth like molars, is it what kind of canal is responding? Is it the mesiobuccal? Is it the palatal ones? And we know there's something vital inside, but we cannot discriminate very easily what kind of response we have. So let's say that nowadays, unfortunately, we are still not able to test properly the vitality of the tooth and to appreciate really if the pulp is without any inflammation, existing inflammation or not. So this is really a weakness of our diagnosis, but this is something that we should do because there is no choice. This is better than nothing. Another thing that we can do by testing a cracked tooth is just testing selectively the pressure cuspid per cuspid. Cusp per cusp, and we use a simple tool for that called the Fract Finder, and the Fract Finder is you are able to put it on different cusp and to change the cusp every time the patient will bite gently on that device, and it will tell you, oh, it's painful on that one or it's not painful on that one. It will help us to make the difference and to try to understand what kind of crack and the location of the cracks that we have, and also an opinion of the on the extent of the crack that we can see. And how can we interpret this kind of response? Is the tool painful to pressure? If it's a yes, if the patient is telling you, oh yes, I can feel it by pressure, when the patient releases the pressure, what happened? If the pain is just stopping, we could consider that the crack is most probably strictly located into the coronal part of the tooth, which is good. If the pain is also continuing by biting, so this is a worse prognosis because it indicates that maybe the crack is going deeper, and we could have some irritation, inflammation, infection of the periodontitis, and some kind of periodontitis or root fracture. So it's a worse prognosis. And if the tooth is not painful to pressure, well, we can still look further for any more cracks, confirming by x-rays that we have maybe a bone loss that could indicate cracks, or we can probe around the tooth, and a deep isolated probing depth could indicate also the presence of the crack, and cross also the information with the vitality testing to lead to a diagnosis of apical periodontitis or root fracture that could not be evident only by testing the pressure on tooth. So probing it, that kind of things that we usually do, well known. If the probe is just going in a very narrow pocket, this could be an indication, a consequences of the existence of the crack, the bone being destroyed in the area when where the bacteria did penetrate. So the conclusion on this diagnosis is that we have many tools. Some of them are visual, under ambient light, under specific light, visual, violet light, etc. And some other ones are testing the tooth and are more, let's say, functional way of testing the tooth. But now we were speaking about pressure, and we should understand very good what happened when the pressure occurs. And especially one crucial question to understand related to that topic is, what is the patient's occlusion like? Because we know that this is through occlusion that pressure will take place. Yes. So usually we're using an occlusion paper, and we will ink the teeth and see some blue, red, green marks, and it's not always easy to translate those findings with the occlusion paper, and we prefer to observe with the high magnification the occlusal clues, which are the wear facets, the places the tooth has been worn, which signifies that we have some kind of pressure over there, we have some kind of load, and we can maybe interpret those worn places, worn areas, to try to figure out what kind of load, direction of load, intensity of load that the tooth is just receiving. Let's take a very simple example with the small cavities. So we can see on those cavities that only with class 1s it looks very simple, but if we pay attention on that tooth, we can see that we have some concave zone, and those concave zone are the information that are really sculpted into the occlusal surface of the tooth, indicating that we have a hard and heavy loading on that part of the tooth. What does it change? It changes only that beyond the visual perception, I have some functional information looking at those worn areas, and I can anticipate maybe a crack. And on that one, we can really easily understand that kind of load on that distal lingual cusp would lead to some oblique forces on that one, and those oblique forces could lead to the existence of a crack in the dentin, which is. So then we know that maybe it will not change the treatment plan, because the planification will do, the schedule will do for a simple class 1, so we will finish with that. But we don't think in our group that only putting some bonding inside of the tooth, replacing an amalgam by a bonded restoration, a direct composite, will be sufficient, will be enough to reinforce the tooth. So actually sometimes we have no choice, but we just have to discuss with the patient and to tell him that that tooth is compromised, and that we could have a further fracture on that one, so that we know that maybe we should do something and avoid on those ones to do a fancy morphology, a fancy convex morphology. We just have to respect that functional aspect on that tooth and create, even if it's a pity, even if it's painful for the dentist that wants to achieve the finest work, we just have to destroy a little bit the composite and just to put some concave areas on it to put a little bit down, to decrease a little bit the loading that we have on that cusp. So apart from informing the patient, we should adapt the morphology to the function of the tooth just to try to make it last a little bit longer. And now we know that the cavity size, it's not the only indication of the treatment, because basically at the university we've learned that small cavities lead to direct restoration and big cavities lead to indirect restoration. This is not that simple, because even if we have a small cavity, but a cavity with a crack, it means that that cavity is not resistant enough and that tooth is not maybe resistant enough. So we should consider that sometimes, even for small cavities, we have an idea that we should go for cuspal coverage and maybe some indirect restoration. And this is not always because of the amalgam. Amalgam is not always the only one to blame, of course, because of the stiffness, because of the expansion over time of the amalgam. This is far to be the best restoration to put on teeth. But think about other material like gold, we didn't have any cracks. So amalgam is, yes, not the best one, but this is also because we have a hole, because we have a cavity, because the resistance of this tooth has been decreased, that we have a problem, not only because of the material. So if we try to summarize a little bit this chapter about occlusion, if the occlusion of the patient is looking destructive, well, on a single tooth, we should answer the question, is that tooth in question the one with the high load on it, is part of the functional path or not? If it is working anyway, we should try something to decrease a little bit the load on that one, like creating concave zones. If it's an overall destructive occlusion like bruxism and stuff like that, well, we enter in the cyclic fatigue of the tooth, and this is no way we should release the load. Unfortunately, we don't know how to do that. There is no specific occlusal concept that we could apply able to reduce that kind of overloading. So then there is unfortunately not any solution, but it's a great tool to know that the overall prognosis of the tooth is decreased, unfortunately. If the occlusion is looking like, let's say, normal, what is a normal occlusion? This is also a good question, but let's say that we don't see anything special. The existence of the crack could be due to the bad cavity design maybe, or to the mismatch between the mechanical properties of the material of the tooth, typically an amalgam in a tooth. So this is how we can understand how the load can explain the growing of some cracks. And then there is a very important question. Once we've done a little bit the diagnosis of this without removing the restoration, and we have diagnosed some cracks, and we just offering the patient a treatment to replace something. The problem is that once we try and we will start to touch that tooth, removing the restoration, a pain will come. And this is one of the biggest disappointments for the dentist and for the patient, obviously. So how could we avoid this to understand a little bit further? We can avoid this understanding maybe a little bit better and diagnose it a little bit better where the crack is. Because depending on the location of the crack, we will have some different attitude in the treatment of that tooth. So where is the crack? We very often have crease lines in the enamel surface, and we know that those kind of cracks are located only in the enamel thickness, it's not really a problem because those cracks are most of the time stopping at the level of the enamel dentin junction. And we know that this is a protection mechanism, a natural protection mechanism that the tooth has, and most of the time nothing will happen. We will not have one part of the enamel jumping out and chipping out of the tooth. It doesn't happen. So there is really nothing to do. Just remember that the natural bonding between enamel and dentin is very high, more than 15 megapascal. So it's almost impossible that something could happen, that some part of the enamel could detach because of one of those crazy lines. The problem is very different when we have a crack in the dentin, in fact, because cracks in dentin are a little bit more serious and should be taken into consideration. Let's take an example. Again, this is a very small cavity, though it looks like nothing, but once we remove the restoration, we can see that the extension of the cracks is going horizontally, obliquely, vertically, deep into dentin, and this will obviously weaken the tooth a little bit more. So, beginning with a very small cavity, once again, we end up with a very deep crack. So, to see that we need to remove the old restoration, of course, and maybe it will lead to some cusp that will have to be covered by an onlay, and for the cusps that are not cracked, we don't have to cover them. So it doesn't mean that once we have a crack, we have to do a full cuspal coverage. It depends, and we will cover the cusps that are the most fragile. And to understand and to take that decision about cuspal coverage, we should understand very good about a little bit more about the biomechanic of the tooth. Well, we had the opportunity and the great privilege to have in our group a great mentor called Graham Milicic from New Zealand, and it's thanks to him that we understood a little bit better the concepts of peripheral rim and of compression dome. On a natural tooth, we have a fantastic peripheral protection around the tooth that is called enamel. And the role of the enamel is to distribute the stress in the tooth. What happens in a natural tooth, in an intact tooth, when we have some occlusal loading? If we look at those moire fringes, those bands, it represents the load, the direction of the load, and also it represents the direction of the load that we have. And the natural tooth is simply able to change a vertical, very heavy loading in a horizontal, decreasing the intensity of that load. So the load that will be transmitted to the root is done through another direction with a decreasing of its intensity. That is what can produce an intact tooth structure, enamel dentin junction, and dentin all together. The problem is that once we have a hole in this system, in this architecture, once we have a cavity, this is really the beginning of the end, biomechanically speaking. Because the teeth will fail in function when their stress distribution system is disrupted by a cavity design. The cavity design, the presence of the cavity will change everything in the distribution of the stress. Because the enamel is really acting as a compression dome, and we understand very good that the top stone of the keystone of that dome is really the class 1 cavity. If we remove that stone, if we put a hole in this place, we know that we will get a problem, that everything will just collapse under pressure. And this is what happened with damaged tooth. An occlusal cavity in a posterior tooth can cause it to flex under compressive loads. It means that we will get a distortion of that tooth, and this distortion will lead to a structural failure of the peripheral rim, which is called a crack. So, and those kind of cracks can extend very far in the coronal part, but also in the root, beginning with a very small cavity. So it can really be something really serious that can even lead to the extraction of a tooth. So, do we have any solution when we are able to diagnose this, when we are able to understand those kind of biomechanical problems in teeth? Let's take an example that is a good summary of everything. When we have those two molars that are painful for the patient to pressure, we can see already some cracks, we can see already some cavities, so we can imagine that those teeth can distort under pressure, and we can have the development and the growing of some cracks inside. Occlusion clues indicating that we have some compressive force on the buccal part if it's a class 1 occlusion patient, and on the other side, on the lingual part, some oblique forces, some oblique loading, which is called the tensile stress. So we don't even need occlusion paper for that, because we see the concavities, we see the worn part of the occlusal part. If we remove the existing restoration, it becomes pretty evident that we have a problem there. Because when we will put some compressive stress on that tooth, the tooth will be able to distort, and as it distorts, because the tissue, because the peripheral rim is stiff, made out of enamel, it will crack under loading, it will crack under distortion. And those compressive stress are producing vertical cracks, cross cracks in the marginal ridges, in the buccal and lingual parts. So this is the kind of lines that we have. Compressive stress is leading to the development of vertical cracks and with a cross distribution on the tooth. And the tensile stress is producing some oblique cracks on the secondary cusp of that tooth, here the lingual cusp of the tooth. So covering the cusp, we will just be able to change the direction of the load, because unfortunately those cracks cannot be repaired. It's not like a fracture in the bone that could be repaired. The tooth will never repair. The dentin will never repair. So we can just put a roof on the top of that tooth in an attempt to change the direction of the crack and to apply compression of those cracks, and hoping that the cracks will not open further. So the conclusion here that we have already is that biomimetic dentistry, minimally invasive dentistry, doesn't mean no prep. Because it does mean no preps when we have no damage on the tooth. When we have a severe damage, we know that we will have to cover cusp. So it means that the design, beginning with the small class 1, can lead to that kind of overlays, which is covering the half occlusal part of the tooth, which is huge. But you can understand that in comparison with crowns, we still have a lot of enamel all around the cervical part of the tooth, which is a benefit, because most of the load is distributed in the cervical part of the tooth. So it could be interesting to cover it, to rebuild that dome that has been destructed by the cavity, and to keep what we can keep on the cervical part. If you want to get more information about that kind of design, we've published in a group some papers on that for the posterior teeth, and I let you take a look in the Dropbox for that. And so the inlays is like a reborn dome of enamel. You can do it in ceramic, you can do it in composite. It will be more or less the same. Personally, I just prefer ceramic to do that, but it will work as well using composite. And after some years, it looks like we have stopped this kind of phenomenon, and the patient is still okay with those teeth. So the conclusion again is that the size of the initial cavity is not, unfortunately, an accurate indicator of the treatment choice, and we should go to understand better where is the crack to take the decision. So we know that on the surface we don't do anything, and when we have cracks in the dentin, if the crack is oblique direction, the question is, what does the rest of the tooth look like? If the rest of the tooth is not distracted, looks good, normal cracks, no very thin walls, for instance, unsupported enamel, well, we can decide just to cover that affected cusp doing a partial onlay, and it will be no problem. We just treat the local cusp that has a problem. But if the rest of the tooth look very weak with further cracks, very weak remaining walls, then we will go for a full occlusal overlay to try to protect that tooth in the future. If we have some vertical cracks, we know that the prognosis is a little bit worse, because those cracks are going along the root, and of course the deeper it goes, the worse the prognosis will be. So it's a major indication of trying to save that tooth doing a full occlusal overlay. So we've started already to speak about a little bit about treatment, so let's go a little bit further into the treatment phase, and especially addressing one very important question. When we have a crack, what do we do with the crack? Should we just cut the cusp, cover it with some inlays, partial inlays, overlays, or should we do something specific with the crack itself? The question is, should we chase those cracks, yes or no? So there is a lot of question about that, and unfortunately few answers. So we have some guidelines, let's say, but there is no consensus in the literature, unfortunately, because any case is a very specific case and different from the other. So the question is, why should we do that? When should we chase it? Where exactly? How much and how, practically speaking, should we do that? So why should we do it? Two reasons for biology. We said that already, that when a crack is open, it's an open door for bacteria. Bacteria will just come in, will just reach the pulp, and will induce some potential pulpal pathology. So we should protect the pulp. Biology is the first and the main justification. For some people, mechanics can also be improved using chasing cracks and trying to put some bonding inside of the cracks. I personally don't believe that we can reinforce a tooth by chasing a crack and injecting some bonding or composite inside of the crack. So for me, the major, let's say, interest and benefit for the tooth is the biology. Then when should we do it? Well, obviously after removal of the old restoration, when we've discovered, when we can see the full anatomy of the crack, and now we can discover even new cracks, removing the old restoration, and also after cuspal reduction. Let's have a look at that kind of situation. We cut the cusp because we see some oblique cracks corresponding to a tensile stress. In the past, I was just letting the things in that situation exactly, not chasing those cracks, because I was thinking, okay, there is a crack, but what will happen? The inlay will just push on that crack and it cannot go further. So let's keep some tooth structure. And we had some failures with that. We have some post-operative sensitivity because of the pumping effect in that crack. So nowadays I have the tendency to drill a little bit further and to eliminate those cracks. Then when we do it, where should we do it? Should we chase the whole crack or only a part of it? So we have to distinguish two different areas: the restorative margin, which is the peripheral part, and the inner circle of the tooth. At the peripheral margins, it should be interesting to chase the crack, because everything that is going out of the tooth is the real open door, the effective open door for bacteria. So this is already like a recurrent way of penetration underneath a brand new restoration. So we have a high motivation to open and to chase those cracks when they lead to the peripheral aspect of the tooth. In the inner cycle, we don't do it usually because we know that we can reach the pulp and we can produce something that is worse than what we already have. So usually we do it on the cervical peripheral part. We don't do it, we don't chase it in the inner cycle part. How much should we do that? How deep? Well, we should try to do the best we can, but the question is that we don't even know till where the crack is. So we don't know the extension. We don't know where is the end of the crack. So we should try to chase it, but keeping attention, paying attention to the fact that we should be able to restore it. So especially if the crack is full of debris, and if we feel good that day to chase that crack because we have a good isolation, because we have a good magnification, and we are able to chase the crack and to make it free of debris and sealable, meaning I am able after the cleaning to seal that crack, to place my matrix and to seal that cracks. Let's do it. So you understand there that it depends on the patient, it depends on the situation, it depends on the dentist, and for the same dentist, it depends of the mood of the day, the ability of the day for the dentist to do that. And it can change from one day to the other, from one patient to the other, from one dentist to the other. This is why there is no rule. If you feel like I can do it, let's do it. It's good. But unfortunately, we are not able to do it because it's something really, really technically difficult to achieve. And the fine question, so technically speaking, how should we do that? Well, we can use burrs or we can use abrasion. If we use some burrs, let's look at this kind of crack, and we see specifically on the first molar palatal part we have a big crack, open crack, wide one, full of debris, and that crack reaching to the peripheral, the outside aspect of the tooth. So those are clear indication to clean it. We have some coloration with the dye penetration, which indicates that there are some bacteria, and we can even use some kind of UV light to confirm that we should chase it because it's full of bacteria, it's an infected one. Well, let's try to find the finest burr that we have in our office, and trying to go from the peripheral to the center, we try to chase it and to clean it at the peripheral part, especially not touching that much the inner cycle. So the deepness of the cleaning is just at the level of the rubidum, and this is everything that we will seal at the same time that we do the so-called immediate dentin sealing, which is a very well-known procedure. Every time we open dentinal tubules, we seal them immediately with some bonding and composite the day of preparation. So once we are doing that, then we will seal at the same time the open crack, and we will fill that gap, and we will change the level of the margin, because the margin of the cavity is way below the gum level, just at the rubidum level. Rubidum level is just underneath the gum level, obviously, and the ceramic cannot go in this very narrow crack that has been chased. So we will refill all this small cavity doing some kind of margin elevation with some composite, just to fill the gap with some material and put the onlay on the top of that material that is filling the inlay. So we have some composite at the bottom part of the cavity, at the cervical part of the cavity, and the inlay coming just over it. Another very nice tool that we use to that is air abrasion. Air abrasion is a very old technique, and actually we are using with a lot of pleasure a device called AquaCare from Velopex that can chase the crack and condition the crack at the same time. Let's take an example. Again, very small cavity, and you see that there is no amalgam here, just a small composite. The tooth is very painful. We have a deep, wide crack at the distal part of that tooth. And we have some pulpal symptoms also. There is a pulpitis for this patient. So for that one, no doubt that we have to do the root canal treatment at the same time. So let's go for the root canal treatment, and then we have to do something with the crack. Wide open, full of debris, with some coloration, with a purple red indication under UV light, which is an indication for chasing the crack that has been infected by bacteria. So we can do that using some powder, and we usually use aluminum oxide of 50 microns under a pressure of 4 bars. 4 bars is a lot. It's a very, very high pressure that we usually don't have on the chair, on the dental chair. This is why we need another device to do that. This is why we're using the AquaCare to do that. And then we chase the crack, make it without debris, clean it of the debris, and just make sure that we are still able to seal it. Then we can even use the air abrasion device to condition the cavity, and we like nowadays to use another powder after the first one, which is a powder of bioactive glass under 4 bar pressure once again, to do some kind of coating on the dentin, which will help to remineralize the surface of the dentin, hoping that it could help and it could improve a little bit the prognosis of that tooth in the future. Sorry. Checking again after cleaning with the UV light that we don't have any red anymore, which is a good sign. And actually we prefer to use, after the root canal treatment being done, we prefer to just feel the bottom part of the access cavity and also that crack using ionomer cement. So this is the conditioning. This is an ionomer that is called a Fuji Triage from GC, and we will cover it with a little bit of composite to achieve the immediate dentin sealing. Ionomer cement are working quite good under compressive stress, so this is why we use it. But actually there is no info in the literature to tell you that if it's better with composite or no. So we just have also an evaluation that we are doing about this technique, and in a couple of years I hope that we have some publication of that to tell you if it's a better idea to do it with composite or with ionomer cement. But this is a detail. Once the chase and dentin sealing had been done, we can fabricate and cement an inlay, recovering the tooth and rebuilding the missing compressive dome. So this is the before, this is after root canal and preparation and chasing, and this is after covering the upper part, the upper occlusal part of that tooth. So, and let's say that from this example we can develop a little bit more what happened with a root, with endodontically treated teeth, because we know that we can have some more problems with endo. Let's take another example. A patient coming from an emergency. This is a necrosis on that one, so know that we have a root canal to do. And this is more or less exactly the same example that we've seen before. So the other one was pretty good. At that time we was using ionomer in the access cavity and some kind of composite, even reinforced composite, to try to do our best to reinforce that tooth and to seal the dentin. And this is basically the same technique, covering everything with a ceramic onlays. But in that case, we didn't get the same result. And only a few weeks after the treatment, we had to face a huge infection in that tooth. Apparently, the work was a good one, but it was not, because along that crack, the bacteria did already propagate and go further in the periodontum, and that has been infected in a very high level. So unfortunately, we just had to extract that tooth, and looking back at my picture, I understood the reason of this failure, because I was not keen enough to looking at the extension of the crack, and it was not only a distal crack. It was a crack going all the way through the tooth and just cutting the tooth in two parts. And I was just focused on the distal part, and I didn't see that, even using a microscope. So it's very, very easy to do that kind of fusion. And once the crack is reaching the pulp chamber, once the crack is reaching the canal, let's say that it's really a highly risky situation, and that the prognosis of the tooth is highly compromised. So we extracted that tooth and did some pictures in scanning electron microscopy to understand that, you see, the crack was already cutting the tooth in two parts. So there was nothing to do to save that tooth, and I was a little bit too optimistic trying to treat it in a conservative way. So what are the endodontically teeth specificities? What makes it different from a normal tooth, from a vital tooth? And if there is some difference, if there are some difference, do these differences translate, how do they translate into difference in the restorative protocols? So we know that the strength of the tooth, it's not really related to the fact that the tooth is endodontically treated or not. This is not a question, for instance, of dehydration or something like that. This is just a question of the amount of tissue that we have lost. For endodontically treated teeth, we have lost more dentin. If we lose more dentin, we have a more fragile tooth. That's it. Dot. That's as simple as this. So the tooth are more fragile, the tooth are less resistant because of the loss of tissue. The endoaccess cavity is a 5% reduction of the relative stiffness. The occlusal cavity is 20% of reduction of the relative stiffness. And when we touch the ridges, the lateral ridges specifically, we have a huge reduction of the relative stiffness of the tooth. So this is why usually endodontically treated teeth and specifically loss of the marginal ridges are critical. And the second reason of the problem, the second specificity of an endo-treated teeth, is that the main pain threshold level is 2 times higher. It means that once we don't have pulp anymore in our tooth, we cannot feel the pressure as good. We have a decrease in the proprioceptive response. So it means that the patient will chew much harder on an endo-treated tooth than on a vital tooth. So we have on one hand a tooth that is more fragile, and on the other hand a decreased proprioceptive response. This is a simple explanation for a higher rate of failure for endodontically treated teeth. So for the endo conclusion, it means that endodontically treated teeth deserve more than the other a full cuspal coverage, and that a crack, when it reaches a canal, is really a highly risky situation. It decreases tremendously the tooth prognosis. So be very careful with that and consider the implant solution. So now it leads us to the take-home message at the end of this presentation. And to be on the safe side with those cracked teeth, we have to understand that cracks are not diagnoses in themselves. They are only findings. And some of them that are very frequent can lead to problems because they are not repairable. We cannot repair them. It cannot happen what happens with a bone, for instance. And not even using some bonding, adhesive dentistry is not magic. And bonding is not magic to reinforce and to repair the tooth, unfortunately. So then we have to think about balancing tissue conservation, and sometimes biomechanics rules are leading to reduction of tissues. So we have to understand and to keep in mind those tensile stress, those disruption in the anatomy of the tooth, and the decrease in the capacities of the tooth to absorb the stress that we have once we have cavities in those teeth. And finally, there is not only one technique to do that. There is not the good technique and the bad one. There are a bunch of possibilities for the treatment, and nobody is able actually to tell you what is the best one. And definitely within this bunch of technique, we just have to choose the one that we feel good with, the one that we can handle the best, because we are end workers, and end workers do a good job when they feel good with that kind of technique. And this is how I thank you very much for your kind attention, and we can keep in touch through the website or some email address, and I hope you enjoy it, and see you later. Bye bye.